Hey guys, why don't we go ahead and get started? If you could please introduce yourselves via the chat to get the CME credit, that would be excellent. Just your name and where you're from would be wonderful. And if you're calling in with a number, just feel free to email me or Caitlin and we'll make sure that you guys are noted for CME as well. So we have two brief didactics today, and Dr. Hodder, I wanted to give the floor to you to do some of those introductions.
Thank you so much, and welcome everyone. As you know, Governor Justice mandated last week testing of all nursing home residents and personnel. You know, in many places in the country, really the brunt of mortality has been really with nursing home populations with many of the comorbidities. And we are delighted that folks from the Bureau of Public Health are with us for the initial session. I don't know if Dr. Slemp or Dr. McCann will be presenting. As you know, Dr. Slemp is the Commissioner of Health and really has had an amazing effect in leadership during this epidemic. I think after her presentation, or whomever is presenting from the Bureau of Public Health, will then take questions that Mitra will manage, and then Dr. Sunil Sharma from WVU, our critical care director, will talk about COVID-19 management in critically ill patients. So Mitra, I'm going to turn it back over to you so we can start our first didactic session.
Perfect. Thank you so much, Dr. Hodder. And Dr. Costello, did you want me to pull up your didactic, and whoever is presenting from your group can just go on ahead?
I think that would be great. Dr. Slemp is on the phone, so hopefully she'll be able to unmute herself. But if you want to share the slides, that would be great. And then Dr. McCann is participating by Zoom as well. So Dr. Slemp, if you're on the phone and you want to unmute yourself, the slides are up.
And if you just let me know when you want the next slide, I'll go ahead and advance it for you as well. Dr. Slump, are you able to hear us? You may be on mute here.
How's that? Can you hear me now?
Oh, yes, that's perfect.
Super, thanks. Well, thank you I love the fact that we can have this conversation. I'm excited to hear from the audience we've got with us. Today we were just going to be talking about management, as you know, of outbreaks in nursing homes with COVID-19. And I'm excited to have Dr. McCann with us as well. He's had a lot of good experience in the last month dealing with a challenging situation. But these are real opportunities to learn from. So if you want to move a little forward, the next slide, I can briefly go through some of the work that's being done and some of the guidance that we've just recently put out. And then have Dr. McCann will speak to some of the practical applications of things. And then I'd love to have some conversation around both lessons learned and ideas, because these are certainly situations that I think we are learning from as we go with the new virus. Lots of unique aspects of COVID-19 in long-term care settings. So we're going to cover the definition of an outbreak. We will talk about some of the epidemiology of nursing home outbreaks in West Virginia. We recently have a very interesting and exciting executive order, 2720, that we'll just briefly touch on, that this is being done in the context of, and then lessons learned and resources moving forward. So our next slide really goes into to what do we define as an outbreak. And as you know, our elderly population is exceedingly susceptible to the complications of COVID-19 infection.
Not right now.
Because we are, we feel it's such a vulnerable population, we actually define an outbreak as a single case of lab-confirmed COVID-19 related to a long-term care facility. So that could be the employee or the resident, because that's kind of a flag to say we need to really look closer in this situation and make sure that we are doing everything we possibly can to prevent further spread. So especially this is true just given that our elderly are in this congregate setting, and it is so easy with the potential for asymptomatic or pre-symptomatic spread to transmit virus in the long-term care setting. And our population there is at such high risk. With our next slide, one of the things that we are seeing, interestingly, as we investigate these outbreaks across the state, is that we actually are finding that often the elderly are not really showing many of the typical symptoms or even no symptoms. So we at times are seeing that it may simply be some malaise or a little dizziness or diarrhea. We're seeing sometimes it's simply a drop in oxygenation level without a lot of symptoms in one situation that we observed. So again, these are not large studies to look at the frequency of each of these, but we're just recognizing that it is sometimes very hard to pick up the occurrence of COVID-19 in our elderly population. And we are seeing around the world that we know that there is asymptomatic occurrence of infection, certainly, and that we believe that could have some potential to be spreading disease and be part of the reason why COVID-19 has been such a challenging disease to really contain more fully. So we do think that looking very closely at our nursing home resident population is pretty important, and having a low threshold for evaluation and testing, especially in the setting in which you've got an outbreak identified, or in other words, another case that is confirmed in a setting. I'll go to the next slide. And we'll talk for just a second about the kind of epidemiology, what we're seeing so far. We have had to date around 10 outbreaks of COVID-19 in nursing homes around the state. And some have been very small, a single case or a few close contacts, did not seem to spread further. And others, when we actually enter the facility and we start to do further testing, we find that there is actually significant spread that has occurred between residents and amongst staff, and that many of those in some of these settings have been asymptomatic. Again, not all, but in some. We also recognize that with the risk of this population, the risk of serious disease occurring and then hospitalization and then sadly death can be much higher in this group, and in terms just by the age. In some ways, we think there's a little bit of a protective effect of being in a nursing home because you're being observed more closely and monitored with this. But we do see that of all of our deaths in the state, over half of them are associated with our individuals who've been involved in nursing home outbreaks. So it is a significant portion of the deaths that we have seen in West Virginia. Now, fortunately, we in West Virginia have seen far, far fewer deaths and are seeing far, far less disease than all of our surrounding states and areas. But we still, every one that we see occur is one too many, of course. So the next slide. Given what we were seeing in nursing homes and the importance of really doing everything that we possibly can to protect and to understand what's happening with our one of our most vulnerable populations in this state, our long-term care nursing home residents, the governor directed back last Friday for both DHHR, the Bureau of Public Health, in conjunction with the National Guard, to, as it says on the slide, immediately test or cause to be tested all individuals that reside or work in the nursing homes throughout the state. And so this really was an effort to really get a point in time understanding of what is the occurrence of this disease among our very high risk population, so we really could identify what's happening, quickly intervene wherever we found the occurrence of disease to make the biggest difference to really protect this population, and then also to understand and learn what's the extent of asymptomatic occurrence in facilities, what are the best ways to detect it early, and what are the best prevention measures, how can we use this to really do all that we can to make a real difference for this vulnerable population, for our nursing home residents, and for the healthcare workers working with them, because many of our cases across the state are associated with healthcare workers as well, and many of those we are identifying are among our nursing home or long-term care population with that exposure. And again, that stems from those outbreaks much more than just individual other settings, but we are finding those through those outbreak investigations. So it was a very novel approach, and our hats off to the governor in leading that. He really has a great passion for this area and wanted to make sure that we looked at everything possible that we could to understand the situation at hand and move forward. We are actually the first state in the nation to do this, although many others are starting to look at how they might do the same or some related surveillance among this population. So the next slide. With the executive order, there are two options that can be undertaken. One is to do this through a single state contract that's available for use, that facilities can tap into that contract, and they will be provided the collection mechanisms and the supplies, and then they can collect assessments, and then the testing is done with a copy of the test results back to the facility. That we've been working with LabCorp to do that. They had a very delayed turnaround time as they were trying to ramp up services. They actually have gotten a much better one now, and we've been seeing that across the state. They are now having a turnaround time of 2 to 3 days. They assure us they can do that with these as well. So we're all in a quick time frame with this. The second option is to do your own testing. Facilities that want to or have already conducted testing independently can certainly do it that way through their own labs or contracted labs they have available. And then we have figured out some nuances of things. For example, we have, as a policy around the state, if we have a case of COVID-19 in a long-term care facility, we actually immediately test all the employees and the residents of that facility right off the bat to understand what's happening right then at that point in the facility as we begin that investigation. And so there were a few facilities who had just done that because they had outbreaks identified in the 48 hours before the executive order. So if that was the case, we're figuring that those entities have complied with the executive order. There was not a reason to retest at that point. Next slide. So the other thing that we've done recently is to issue some guidance around long-term care facility investigation and management. There are lots of materials and tools out there. We thought it'd be helpful to have something a little more specific to West Virginia, but we encourage folks to use a variety of resources. Dr. McCann is both an associate professor at Marshall and School of Medicine, Department of Family Medicine, as well as a practicing clinician in the community in Wayne, and happens to be, fortunately, the Wayne County Health Officer. And we have worked together for many years. He's a great local health officer and very engaged there, and has just recently had quite the experience of addressing one of these outbreaks in the facility that's associated in his county. And so, Kevin, I'll turn it over to you and let you talk about some of the lessons learned and the issues that you saw that were raised, and we can begin some discussion to follow about managing these situations.
Well, hello. Can everyone hear me?
We sure can.
We are day 16 in the outbreak that occurred in Wayne County, West Virginia. And the key elements that stand out to me are, one, how rapidly this developed and the need to bring together multiple team players when an event like this occurs. The other is the increased mortality that happens in this setting, and realizing that that mortality, it was pretty obvious that it was partly due to age and partly due to high comorbidity. But the other thing that stood out to me that I didn't realize at first, there was just a high frequency of people who have chosen palliative care only. And that's another thing that drives the mortality rate up. And that, I think there may be an element of educating lay people to that, so that they can interpret those higher numbers when you have a nursing home outbreak. Our outbreak began on 4/7/20 with a single case, and the next day we were on 4/8 we were up to 4 cases, and the third day we were up to 17. When responding to this, as in this role, my role was as health officer for the county as opposed to treating physician at the facility. But as health officer, the thing that I found really useful was that Dr. Slemp and the West Virginia Bureau of Public Health, fortunately, were working on a draft document to address nursing home outbreaks. And they provided me with that, and that was a tremendous resource. The approach I took with that was to basically use that as a checklist to see that we were addressing all identified factors that could potentially mitigate a situation like this. The issues that come up when dealing with an event that's of this size, because at our facility by 7 days we had went from 1 case to 65 cases, and as of today we're up to 81 cases and 6 deaths. The bringing together and helping coordinate the nursing home, medical director, director of nursing, establishing a relationship with the closest local hospital, establishing relationships between specialty care in infectious disease, critical care, bringing together people who can help supply additional PPE or testing materials. This bringing multiple people together once or twice during this process was very helpful, because it could help rapidly identify where gaps were in care and help establish logistics of getting people tested. The thing that I have seen come up a lot with COVID-19, and again was present in our issue, is just how fluid things are. You know, the approaches that we learn today, or the regulations that we learn tomorrow, may not be those that are there next week. And that becomes, I think, part of dealing with this unique problem that none of us have experienced in our lifetime. So that's about all that I had as far as comment.
Excellent. Thank you so much. Would you like me to advance some of your slides? I think there are about 2 slides left. That's good. Okay. So Dr. Slemp and McCann, thank you both so much. If you guys can stay the whole session, that would be excellent. And we can do your questions at the end. I believe there was one that came in regarding your didactic, but if you do have to hop off a little earlier, then we can ask those questions right now if you'd like.
No, I'd be happy to stay on. I'd love to hear the conversation and learn together. Kevin, what's your schedule like?
No, I'm good. No one's supposed to come through my door for another 30 or 40 minutes.
All right, excellent. Well, thank you both so much. We'll do all the questions at the end, just so we can also do Dr. Sharma's didactic as well. Dr. Sharma, would you like me to pull up your didactic if you're ready?
Let me just interrupt, and I wanted to introduce Dr. Sharma, but I wanted to thank Dr. McCann and Dr. Slemp, and fingers crossed that nobody's going to come through your door because, you know, as you said, it's a very fluid situation. I think the value of these sessions is really the conversation. So thank you for staying. I'm going to introduce Dr. Sunil Sharma. He is a professor of medicine at WVU School of Medicine and director of pulmonary and critical care. And he's really going to bring us what is known about management of critically ill patients. So Sunil, are you on?
Can you hear me, Sally?
Yes, perfect.
Awesome, great. Well, thank you very much, Sally, and good afternoon to everybody. This is a huge topic, trying to manage critically ill patients in COVID-19 here at WVU, especially in relationship to a rapidly evolving scenario. My lecture 2 weeks ago is no longer valid, so that I can tell you how quickly this disease is moving. So I'm going to provide some insight of what we are doing in terms of management of critically ill patients with COVID-19. So we're going to go to the first slide here. So as you all know, COVID-19 is the disease and is caused by the severe acute respiratory syndrome coronavirus 2, which initially was reported in Wuhan, China in November of 2019. And basically, the target organ that we have understood is the lungs, where 85 to 95% of the patients are landing with pneumonia and eventually going into ARDS. And that's supposed to be, the mechanism is that these cells have abundance of ACE2 receptors, and that is the portal of entry of this virus, and hence the lungs not necessarily also being in terms of contact with environment are prime areas of attack by this virus. Next slide, please. So on a basic intensivist ICU care, what do we see? We see these 4 core issues as our main battlefront in the ICU. One is a profound and prolonged hypoxemia, where it appears that even with the radiological images not showing significant amount of infiltrate, the amount of hypoxia is just outstanding. And we believe it's because of severe VQ mismatch, and that's one of the critical points that we deal in ICU as to how do you oxygenate these sick patients. Sometimes we are very surprised that these patients may actually be looking very good. Some of them are on their cell phone and maybe even chatting with us, and yet their oxygen is very low. So it's a very interesting dichotomy as opposed to other pneumonias where it goes hand in hand, where hypoxia is also connected with the symptoms, and they're extremely dyspneic and barely able to talk. The second unique thing which distinguishes this disease from other ARDS and pneumonia is the cytokine storm, which we have started seeing somewhere around the 6th or 7th day, and kind of dictates the course of these patients in the ICU. The patients who go into these severe cytokine storms are the ones who land up with a lot more complications and may also have a bad outcome. You must have also heard that as we learn about this disease, we are noticing not only from our own experience, but from European experience and the Chinese experiences. For some reason, this ARDS is associated with a hypercoagulable state. So far to say that the D dimers are significantly elevated in many of these patients and are also a marker of bad outcome. So if you follow D dimers in ICU, patients who do bad and have a bad outcome are the ones whose D dimers doesn't come down and continues to escalate despite best management. And the fourth, of course, as you know, anybody who stays in ICU for a long period of time, as these patients tend to do, starts having secondary infections and problems, which eventually lead to multi-organ failure and a hemodynamic collapse. Next slide, please. So it's strange because about 2 weeks ago when I took this lecture for our own group, I did not start with this slide. I started with a ventilator slide. And it comes to say is how much has changed in these 2 weeks' time. 2 weeks ago, we were convinced that this is a severe ARDS. These patients need to be ventilated very quickly and put on what is known as ARDS-NET protocol, where we give very low volumes, a very high PEEP to these patients in the hope of reversing intractable hypoxia. However, that understanding has somewhat evolved over the last 2 weeks, and we are seeing that patients who are placed on the ventilators actually are dying more. I'll take your attention to this morning's news in CNN, which reported that one of the hospitals in New York, 88% people who were placed on ventilator died. 88%, which is mind-boggling to us as intensivists. So what we have done is we kind of revised the way we treat this, and in the absence of any randomized controlled trial, we are learning as we treat. And our new strategy is to continue non-invasively supporting these patients and preventing and delaying intubation. So our number one a methodology for doing that is the high flow nasal cannula oxygen, which can be delivered at the speed of almost 40 liters or to almost as high as 60 to 70 liters per minute. And we had some success. In fact, 2 of our patients who we continue to avoid intubation, despite being extremely nervous, they turned around corners around 5th to 6th day and actually were able to leave the ICU and go back to the floor and doing very well. So this is kind of the domain we are operating at this time, which is quite changed. The risk of aerosolization is somewhat exaggerated. I'll give you an example. If somebody coughs, they generally produce aerosol at the speed of about 400 liters per minute. And high flow oxygen cannula generally can be operated safely at 40 liters per minute. So drastically very less amount of projectile coughing or the speed of which the aerosol is disseminated. So we generally are using high flow oxygen without any issues in the ICU. And we are trying to keep the flow rates below 40 liters. Occasionally we had to go higher than that. And to reduce the amount of transmission in the room and protect our healthcare workers, we are asking our patients to use a surgical mask on top of the high flow nasal cannula. Next slide, please. Next slide. And most of you must have heard about prone positioning. There's good randomized controlled trials. However, this was always done in the domain of ARDS, patients who are intubated, paralyzed, heavily sedated. However, we have kind of started utilizing prone positioning even in non-intubated patients. And these patients do prone positioning mostly on voluntary basis. We ask them to, after having a lunch for an hour or breakfast for an hour, we ask them to lie on their belly for about 2 hours as tolerated, at least 3 times a day, with the same thought, the mechanism that would improve their hypoxemia, that would improve their VQ match, and that would delay their need for intubation, and hopefully in the time period, their immune system will kick off and start improving the disease process. So this has been going on both on the floor, but definitely in the ICU. On the 2 most recent cases we had, we were successful in getting these patients in prone position as much as they could tolerate. Of course, we need to avoid this in patients with altered mental status, BMI of over 40, or if they have any ascites, we generally try to avoid that. Next slide, please. Another armamentarium we have is called inhaled nitric oxide. And inhaled nitric oxide is not a new therapy for us. We have used that in ARDS for many years. And what basically it does is that it provides improved VQ mismatch by causes pulmonary vasodilatation in those areas of the lungs which have good ventilation also. So it has been shown to improve oxygenation very quickly in other ARDS patients too. But in this setting, there's some in vitro proof that inhaled nitric oxide or nitric oxide may have antiviral potency and efficacy too. So for those reasons, we are jumping on inhaled nitric oxide much earlier than we would have done or have done in the past in ARDS patients. Having said that, we have the capability of using inhaled nitric oxide with high flow canula, so we're not dependent of having the patient ventilated. So those 2 patients just recently seen in the last week who did very well and did not require intubations were the ones we use high flow oxygen and inhaled nitric oxide very quickly in succession, and they turned around after 3 to 4 days and were sent back to the floor. Of course, there's some limitations with inhaled nitric oxide. After 3 days, we start noticing tachyphylaxis. The maximum dose we use is 40 parts per million. Beyond that, we may start seeing some systemic hypertension, so we avoid any higher doses of inhaled nitric oxide. Next slide, please. Antimicrobial therapy. You guys have probably known a lot about hydroxychloroquine and azithromycin. We in the ICU are not that much sold on this therapy. The reason we utilize this is because when the patients come to MICU, majority of them are already on hydroxychloroquine and azithromycin on the floor. Many times we land up actually taking them off. And most of the reason why we take them off is because we start witnessing QTC interval enlarging to more than 500 milliseconds, or we start noticing frequent PVCs, which makes us nervous, and we have discontinued this medication. Just to remind you folks that this new study came up with hydroxychloroquine, which did not find beneficial, maybe increased death, and the NIH panel yesterday recommended against using hydroxychloroquine azithromycin. We definitely keep a very close eye on secondary infections. As I alluded to you, the more time they spend in ICU with their immune system, they are more likely to get a secondary infection. We often, other than noticing their white count and fevers and other signs of infection, we monitor procalcitonin, and it's a useful biomarker because sudden increase in procalcitonin suggests that there's a secondary infection, and that's an indication to broaden their antibiotic coverage. Next slide, please. Anticoagulation, as I alluded earlier in the talk, these patients are showing us extremely hypercoagulable state. And some of the problems which we are witnessing is because of the systemic microemboli. Some people believe that these microemboli are what's responsible for the myocardial damage eventually. Elevated D-dimers are predictors of poor outcome. So our policy in our ICU is that if we find that there's no significant risk of bleeding, we are putting them on trauma doses of anticoagulation, usually Lovenox 0.1 to 1 milligram per kg every 12 hourly. If they're like somebody has an ulcer or actively bleeding and hemoglobin is dropping, we still end up putting them in at least on heparin sub-Q 5,000 BID. My understanding is that there's some kind of anticoagulation prophylaxis now also occurring on the floor patients who are not that sick just because of this issue. And we have a very low threshold for screening these patients for DVT and treating them very aggressively. Next slide, please. Coming to more specialized treatment, as I again mentioned in the beginning of my talk, there are two things which are really killing these patients. One is this extreme, profound hypoxia, and the other guy is this cytokine storm, which eventually leads to ARDS and multi-organ failure. So we are addressing both of these at the same time. We don't have very good options at this point. At here, we have an IL-6 inhibitor, which has been used in cytokine storm by our hemonc colleagues in the past, and has some data, anecdotal data that it works. We generally get an IL-6 levels in these patients if they are elevated and these patients are circling down the drain. We will use tocilizumab in these patients. Lately, we have had success with steroids. If you guys remember, initial society recommendations came back as not useful and do not use steroids. We do not find those recommendations helpful. And we have been using these steroids for reducing the cytokine storm. Both those patients who did well and left the ICU were actually placed on steroids in the beginning too. And then we have some experimental data in which we are doing a randomized, not a randomized, but an initial phase trial on stellate ganglion block. And just briefly, the idea behind it is that these are sympathetic ganglions located in the neck region, and they take the information of inflammation from the lungs, pass it on to the brain. The brain gets too excited about that and then start dumping out a huge amount of sympathetic activity, which we think then further escalates the cytokine storm. So the idea is if we block these sympathetic and stellate ganglion, which is a simple procedure, that hopefully we will prevent the sympathetic storm from happening. Next slide, please. We also have approval for convalescent plasma transfusion. And again, the idea behind it is that patients who have already recovered from COVID-19 have had strong antibodies, hopefully, against that. And if we use this passive plasma and can neutralize some of these antigens of the virus in active patients, then that may be helpful. We have had trouble getting convalescent plasma because it's dependent on donors. It has to be screened and matched, and that's a substantial obstacle. So we haven't used it, but this is something which we are looking forward also. Next slide, please. Eventually, if nothing works, the patient do have to be intubated. Just a brief points about intubation. Our understanding in the last 2 weeks has been that we need to really avoid high PEEP. I think the more we are inflating these lungs, the more trauma we are causing to these lungs, and there's more influx of these cytokines and bad elements inside the lungs. The way we have start looking at the ARDS now is that there are 2 types of ARDS. One is the L type and the H type. And the COVID seems to be belonging to the L type, where there's low elastance and a normal compliance. So these are the patients who can get really hurt if you really extend their lungs. and put them on ARDS NETS protocol. So our advice is that patients, even if they get intubated, and if as long as their compliance is not very high or very poor, then use regular settings of your ventilator, which you use for any bread and butter pneumonia, which is normal tidal volumes, avoid high peeps, and keep the drive-in pressure around less than 15 centimeter. We generally start proning these patients at around PF ratio of about 150 or below. We obviously need to make sure they are very well humidified through the vent settings, because we are seeing a lot of casts, which necessitates sometimes doing a bronchoscopy to remove these thick casts. And these patients tend to remain on a ventilator for a very long period of time, and they develop neuromuscular weaknesses, which makes it very difficult to get them off the ventilator. So we have started trying some new strategies where when these patients have sufficiently recovered, but they are still hanging on to these major ventilators, we actually wean them on to non-invasive ventilators. And non-invasive ventilators, by the way, can also act like ventilators, especially BiPAP STs, and they can provide enough support for these patients. And one of these patients, which we did this and used this technique, is doing extremely well and is being transferred out of the ICU. Next slide, please. Again, we are trying to avoid high-risk procedure as much as possible. Sometimes it's not possible. We have to do bronchs on these patients, especially if there are thick casts or there's a lung drop. If that happens, we need to make necessary arrangements, making sure these people are in negative pressure rooms, airborne infection isolation, and using proper PPE, including PAPR, gown, gloves, and shoe covers. Next slide, please. We have been promoting for a long period of time that non-invasive ventilation is dangerous, shouldn't be used, cause aerosolization. And we may be stepping back on those really strong recommendations. In fact, we are starting thinking of using non-invasive ventilation, especially when we heard from New York that most of the patients on the ventilators are dying or having an extremely bad outcome. And our own personal experience at WVU, that if we delayed intubation, these patients did better. So we are thinking that if high flow oxygen fails, then maybe we should take a jump and then use non-invasive ventilation as a bridge and still try to preserve and can prevent these patients from moving forward to be intubated. We have come up with techniques which will reduce the amount of aerosolization by using non-vent mask and using a special expiratory port called DEP port so that the exhalation gases don't collect. And we use HEPA filters, which can filter all the viruses and the bacteria. And using proper good fitting mask can reduce the risk of aerosolization significantly. Next slide, please. Secondary infection, I've already alluded to you, very high risk of that, and that's what we think leads to multi-organ failure and eventual bad outcome. We continuously keep an eye on that, continue to use procalcitonin as a biomarker to help us define the onset of secondary infection and then very aggressively treat these secondary infections. Next slide, please. ECMO is a last resort. We haven't used it in time, and national data suggests that preliminary patients who were placed on ECMO did not have a good outcome. That paper has been released, so I would encourage you guys to look into that paper. So I think the problem is with the VQ mismatch initially and the cytokine storm. And if you can manage that adequately in the beginning, these patients tend to do much better. And if you go in for much more aggressive treatments, and that, in my opinion, is leading to more lung damage and more aggressive cytokine storm. Next slide, please. So the take-home message, as I said, is a rapidly evolving understanding on the management. What I said 2 weeks ago is no longer valid. What I'm saying right now may not be valid tomorrow. So take it with a grain of salt. The current MICU strategy, based on our experience and our talking to various other intensivists throughout the country, is to avoid and delay intubation as much as we can. Absolutely avoiding ARDS-NET vent protocol, which we have successfully used in other ARDS patients over many, many years. Consider high-flow nasal cannula, early nitric oxide therapy, and consider non-invasive in select situations. We also strongly consider anti-inflammatory agents in the beginning to reduce this cytokine storm, including steroids, IL-6 inhibitors, especially if there's no contraindication. We also recommend anticoagulating these patients if there is no bleeding risks, and continue to learn by engaging ourselves in trials which we think pathophysiologically make sense, especially with stellate ganglion block, convalescent plasma, and other treatments which are emerging as we speak. So thank you very much for your attention. Hope this kind of gives you a 30,000 feet view of what we are doing in ICU, and I'll be happy to take any questions at this time.
Sunil, thank you very, very much. We want to get to questions, which is always the best part, but I did want to introduce two other individuals, Dr. Arif Sawari, who of course is chair of medicine at WVU and an experienced infectious disease physician, and also Dr. Krupicka, who is the chief of hospital medicine, and they have joined our hub to field questions as well. So Mitra, I'm going to turn it back over to you so we can get to all these good questions.
Perfect. Thank you so much, Dr. Hodder, and thank you so much, Dr. Sharma. That was excellent. So the first few questions we got, I believe, are in regard to the first didactic we had, but anyone is more than welcome to chime in as well. So how are nursing homes currently planning to handle post-rehab patients with respect to COVID-19 testing? And do we have testing capacities to handle the volume of these patients to be transferred from the hospitals to the nursing homes?
Dr. McCann or Dr. Slemp?
I can speak to it a little bit here, or Lisa or Dr. McCann may want to chime in as well. As you know, there is a CMS recommendation that an individual be tested and have a negative test and transferring back to a facility. Does not necessarily say you need to hold transfer for that. However, several policies among different long-term care facilities are looking at that. I think what we look at it is that what's most important is that the facility have the ability to manage patients that they have an unknown status. Because if you take a test on Monday and they are negative, does not necessarily mean that they will be on Tuesday, Wednesday, Thursday, etc., given the incubation period of 14 days. So this is a really tough issue, tough area, because we really want to make sure that we do everything we can to avoid introduction of COVID-19 in these facilities unwittingly. At the same time, we've got to keep patient flow and care going. And so this has been an area, I think, of debate nationally and here as well. At this point, we've been really emphasizing the importance of facilities having the ability to isolate individuals when they come back for that 14 days to really be able to assure or assess and make sure they're not developing symptoms, et cetera. I don't know if others want to speak to that. This has become a really challenging area around the state. And thoughts you might have on best ways to manage it.
I don't know, Dr. McCann, we can't hear you if you're on mute.
I think that something that came out to us at Wayne as a possible solution to help is in designing the kind of floor plan for isolation and other sections. And we actually identified potentially there being 4 sections. One would be your COVID unit, and that seems to work well to put at the end of a long corridor with an external exit and an external ventilation system so that employees only enter from the outside. They don't walk through the rest of the building. And that can be handy in critical staff shortages, because if there is, if you happen to get in a situation, there is no staff at all, there is some precedent for allowing asymptomatic positive staff to work in the COVID unit with COVID positive residents. So at one end of your corridor, you have your COVID unit. At the very opposite end of the building, as far away as possible, you would have your immunocompromised patients. Then after the COVID unit would be a section of people that we're really not sure of, folks that we are monitoring. One group that fell into this was with our new testing that's been done the last couple of weeks, and really especially now, we have people that are turning up positive as part of really a screening procedure. And none of our advice really was set to address those people, because you'll have people that are positive, that are asymptomatic, and if we treat those like an isolation case, then 7 days from now you may be taking them out. Well, that's a little soon, but then they're not quite a typical quarantine either, which is somebody who was exposed and you're giving them 14 days to develop symptoms. So you go from your COVID unit to, where people we're not sure of, then to your typical floor patient in your long-term care facility. And lastly would be the immunocompromised.
There's also, I know I've talked to folks dealing with this in a facility, and you have to be very careful about moving patients across wards as well. And so this is what's really challenging in terms of managing the cohorting in events, but the concepts are really helpful there. I think the question was getting at too, the patients that have had the hip replacement and need to go back for rehab that are not, we don't know they've been exposed to COVID-19, a very different setting than in an outbreak setting. They've been in a healthcare facility, they're concerned they could be, and we need to be able to move them back. I think it does speak to the importance, whether it be an outbreak or other setting, that facilities be able to manage and handle and have plans in place for handling a patient that is of unknown status with that. Similarly, when we have outbreaks, the importance of making sure that the patients that don't need the clinical care of the hospital can be managed, and we can support the facility and the medical leadership there of managing them in the facility. Because the vast majority of patients are actually, we're seeing, being able to be taken care of in the facility. I think I think we've had 158 residents who have been positive through nursing home outbreaks in the state. 29 of those have been hospitalized. So the vast majority being handled in the facility. And so that's where the kind of things that Dr. McCann and others are thinking through, how do we best manage those within that facility. And so your transfers back to the hospital are really more related to the clinical status of the patient than needing to. It shouldn't be driven by the fact that you can't handle it in the facility, but that's challenging. Some of our facilities do have difficulty in having the right structures or hallways or maps that can work to do this in a practical way.
Thank you. We've got a lot of questions. So Mitra.
Yeah, we do. And we have about 6 minutes left. So we'll try to get to at least 2 or 3 more. The other one is, should older patients with chronic diseases consider low-dose aspirin as prophylaxis?
Who would like to take that? I don't know, Sunil or Arif or?
Yeah, I mean, I don't think there is any evidence that aspirin helps in any way. that I know of. Once these patients get into COVID positive, there's some hypercoagulable state as we discussed, but as a prophylaxis, taking aspirin, I think at this time would be pretty much voodoo science, just like taking hydroxychloroquine for prophylaxis.
Perfect, thank you. Another question was, there have been many patients asking if they should take vitamins to boost their immune system, but because of the cytokine storm, what should they tell the patients? Any thoughts?
Again, I think these are all anecdotal evidence. I mean, vitamin C, zinc, all of them have been touted to have antiviral properties, but whether they really work in this situation, nobody knows. I don't think it's going to hurt taking vitamins. At the same time, there is no evidence that it's going to prevent you from having COVID-19. I think sometimes these things distract us quite a bit, and we don't pay attention to the real things like social distancing, washing our hands, keeping away from people who are sick. So sometimes, we don't want to make sure that these people are not distracted in the wrong way. So I don't think there is any harm, but I don't think it's helpful.
Thank you. Another one was, what about recombinant antibodies? Is this the same theory as the plasma?
I'm sorry, what was that again? Recombinant?
I believe it's in regard to one of the slides in your didactic. It says, what about the recombinant antibodies? Is this the same theory as the plasma?
The plasma which I was talking is the convalescent plasma. This is plasma obtained from patients who already have successfully been treated for COVID-19. So hopefully there are specific antibodies generated against the COVID-19 virus. Now, just having generic antibodies against this, we don't know whether it's going to be helpful. I don't think there is any trial. I don't think there is any evidence that that's going to be helpful.
Yeah, let me just comment. I think they may have also been referring to monoclonal antibodies that are, engineered to be have high affinity for the virus. And as Sunil said, there are no studies with those, though I know people are working on them. There is a precedent in other viral illnesses, such as Ebola, that monoclonal antibodies have actually been efficacious in improving outcomes. Whether that will be the case in COVID-19, we have no idea.
Perfect, thank you. About 3 minutes left. The next one might be a little longer, but I'm gonna ask it and put it out there. I have heard several people, including physicians and nurses, say that they are sure coronavirus was in the US and West Virginia before February. And earlier this week, there was a report in the New York Times about 2 cases in Santa Clara County, California, that have been determined by autopsy to predate the first cases in Washington state. So the question is, could there be any truth to these rumors by people that the virus was much earlier?
Dr. Slemp, do you want to take that one?
Sure. We are hearing the same. And certainly it's possible. I think when you're dealing with a new disease and a new virus, and you're dealing with global travel, and we are all interconnected, and a virus that we increasingly are learning can present either with asymptomatic occurrence of infection, or that has similar symptoms to flu. And you've got that in the middle of flu season. I think we are going to be learning more as we keep looking at where and when things are introduced. Others want to chime in on that, or other thoughts?
No, I think you're right. Maybe we can get to another question or two.
Sure. Let me get one more question up. So, knowing the earlier studies on COVID-19 showing a higher vulnerability of older population, why didn't we protect the nursing homes and the enough through a stronger mitigation plan.
I can speak to that some as well, and I will say that the nursing homes were actually the first step that we took. And the industry was very proactive with this, and we were in contact with them really early. So before we ever had a first case in West Virginia, before we were doing any of our social distancing measures, et cetera, it was actually the nursing homes that we worked with first, and they took the CMS had come out with some guidance. The guidance had actually been to begin to implement the strict visitor restrictions when you had it in your community. And we actually worked with the nursing home industry. Everyone decided that we should do that in West Virginia before it was in the community. We did not wait for that. So we actually did begin that. It was the first measure that was taken by anybody in the state in terms of mitigation pieces with that. So it was very quickly done. The industry took it very seriously. They've been putting those in place actively ever since March, early March. That's the area we really were focusing on. I think we're also learning what are the best ways to prevent it, and how do we do that given the asymptomatic introduction.
Perfect. Thank you so much. I do want to thank everyone who presented today. All the didactics were excellent. Any questions that we do get, we will address them next session. Our next session will be on April 30th, and they are extended until May 14th. As far as we know, we might have to do more or less, but May 14th as of now too. So thank you all so much, and thank you, Dr. Hodder, as well, and we'll see you all next time.
Thank you.
Thank you.
Thanks so much.